You need to remember what chemical category dopamine fits into, right? But that's memorization. Treat that part like anatomy, right? You just have to like get it into your head holes and figure out a way to bring it back up. And the reason it's important is because what if I used which catecholamine does blah, 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 and you didn't know which one was a catecholamine, right? Then you can't answer the question correctly, even though you know what it does, right? So why the hell am I making you memorize the chemical categories? Because as you get into clinical pursuits, the chemical categories determine the group, right? The group of drugs that are all similar, the group of neurotransmitters that are all similar. So it seems kind of arbitrary, but I wouldn't make you learn it if I didn't think it was going to be important in the future. And you will miss simple questions if you don't actually learn categorization, okay? So let's go back one real quick before we get into the new ones and say, first question is, last thing that we talked about last time was the biogenic amines. What the hell do I mean by biogenic amines? How do you make that meaningful for you? What does it mean? What is, I'll be nice if you're brave, I promise. What does a biogenic amine? What? Yeah, it's derived from an amino acid. I take an amino acid and I just like change one bond or add a group or take a group off, right? It's about the same size as an amino acid, but you can't make it a protein out of it anymore, right? So it's basically just a modified amino acid. Okay, so she's right about that. So now, the first category of biogenic amines that we talked about last time was the catecholamines. What do these have in common? They're all derived from what? Do you remember? They're all derived from tyrosine. So the reason that they are chemically similar, FYI, is because they all come from the same amino acid that just has minor changes. You got me? Okay. Do I care that you can recognize any one of them chemically? No, right, at this point. Do I care that you know that they are all going to have very similar shapes? I do care about that, right? Okay, so what are the three catecholamines? Dopamine, yep, and? Norepinephrine and epinephrine. Good. Okay. Oh, I need the short answers. Sorry, I forgot to ask for those. Would you just pass them that way and I'll walk around and grab them? Okay. Dopamine, norepinephrine, and epinephrine. Good. Okay. So where we're going to go after that is that the last one we're still reviewing, so we're not doing anything new. Serotonin was a biogenic amine, but it wasn't a catecholamine. Why? It's derived from a different amino acid. Which one? Yeah, this one's derived from tryptophan. So do you think, just applying your information, do you think that the receptors for serotonin, oh, that's not how you spell serotonin, that's serotonin. You can keep this. Do you think that the receptors for serotonin, not serotonin, are really similar to these? No, they're different. This is a different amino acid, right? Derived from a different amino acid. Does that make sense? Okay. So serotonin is the last one we talked about last time. And now all we have to do is add one more to this category. So it's still a biogenic amine. And this one is called histamine. And the only reason I'm telling you about histamine is that we just recently discovered, not histamine, but that histamine is actually the primary neurotransmitter used by the hypothalamus. That sounds pretty damn important, doesn't it? Yeah? The hypothalamus does damn near everything physiologically. And so the reason I'm telling you guys that the hypothalamus primarily uses histamine is because that will probably be important physiologically in the future, both with research, with medication, with all kinds of stuff, with circadian rhythm problems, right? There's some serious circadian rhythm problems that happen in blind people. There's circadian rhythm problems that happen in people who are incarcerated. So histamine. Now, you knew histamine before, but you knew histamine as a paracrine agent used in allergic responses and injuries, right? So now I'm telling you, as I told you at the beginning of the semester, once the body learns how to make something, it can use it any way it damn well pleases, right? So in this particular instance, histamine is being used as a CNS neurotransmitter in the hypothalamus. Yeah? Okay, so we don't have any clinical importance for it yet, but I would bet that we will. So I'm just telling you guys about that one just a little bit. So I would predict that the research will be kind of interesting about it within the next 10 years. Okay, so the next category that we are going to talk about is a huge category of neurotransmitters. Go ahead.
You said you were going to talk about the clinical situation in MDMA?
Oh, MDMA. Oh, I forgot to tell you guys about clinical situation. Oh, okay, thanks for reminding me. Okay, so let's go back just a second, because Rejoice, remember that I was going to tell you about clinical applications of MDMA. Okay, so serotonin, right? Serotonin is, among other things, a mood-regulating chemical, right? But it has a whole bunch of other functionalities, hunger, sex drive, a bunch of other stuff. So MDMA, which is ecstasy, MDMA was developed initially. It was not actually developed as a party drug. It was actually initially developed as a drug for use in therapy, but then it's really pleasurable, so people started using it as a party drug. And then it actually became outlawed, right? And so it's still a Schedule I drug, which means that the government says there's no official approved purpose for it. So it's really difficult to get research funding for Schedule I drugs, right? Because you say there's no official approved purpose for it, and they say, well, I can't find an approved purpose unless I can research it. And then you get stuck in this little loophole in which you can't find any money to figure out whether it's actually going to be useful. However, there's a group about 5 years ago that got approval to do a clinical trial for MDMA for PTSD. And PTSD is really notoriously resistant to both talk therapy and chemical therapy. People who have PTSD sometimes have it for decades on end and really never get much relief from it. And a lot of times there's a lot of addiction associated with PTSD just to try to manage the symptoms. So they figured out that with MDMA, one of the things that when MDMA was originally used in the 1980s, it was used as a therapy drug. And it was used for instance, marital therapy. So a lot of times what happens with couples, especially if they've been together for a long time, and you've probably been in one, so you know, is you get so much freaking crap built up and resentment that you never actually are talking about the thing that you're talking about. And so you can't actually get past the resentment barrier to actually have an honest conversation about the thing that's going on right now. So they started using MDMA with a trained therapist and a nurse with couples, right? And one of the things that a massive dose of serotonin will do is it will reduce your sort of trust inhibitions. It will make you more likely to trust other people. So what they did in the 80s was they would use weekly therapy, but once every 4 weeks they would use it with MDMA. And they said, this was the quote from the 1980s that was actually in the testimony before the FDA. They said that one session with MDMA and a trained therapist was like 1 year of therapy. It reduces your inhibitions to, it makes you more likely to trust and you can get through things. So someone about 5 years ago said, well, you know, PTSD is really you get really stuck in an experience and you can't really traverse the experience to actually get to the other side of it. So I wonder if MDMA would be useful. And it took forever for them to actually get approved to do a clinical trial, and then they did about 5 years ago. And so they set up a 4-month clinical trial situation in which they were going every week for 4 months, right, with a trained therapist. And once every 4 weeks, so there were 4 total sessions, with MDMA. There were 4 total sessions. Once every 4 weeks, they would use MDMA. Because if you use it really regularly, you'll get downregulation. And so the first set of clinical trials was with people who were survivors of violent situations and rapes and things like that. And after that one was successful, they actually started using it on soldiers with PTSD. So the second round of clinical trials got approved to be used on soldiers. And so how effective was it? About a 67% relief from PTSD symptoms that was retained over the first year into the second year with a 4-month treatment. So this is even without repeated treatment. So it was incredibly effective. So in all likelihood, this will probably be a legal therapy to be used with a doctor in other states. In this state, you might want to travel to California. That's all I'm saying. All right? If you got PTSD, you might want to get mobile. Because we still can't even agree on marijuana in every freaking state around us. And we'll talk about marijuana today too. Hopefully we'll get to it. So anyway, that's the clinical use. There's some really interesting research papers. You guys know about scholar.google.com, right? Okay, so if you want to look for real research and you don't want to get Joe Blow's homepage, anti-vax homepage, or some crap like that, don't ever repost anything by David Avocado Wolf, all right? He's an idiot. But if you want real research, peer-reviewed and published, go to scholar.google.com, and it'll pull up peer-reviewed articles instead of just crap, okay? Okay, so thank you for asking about that, Rejoice. Okay, so let's see. I forgot where were we now? Okay, amino acids. All right, so this is the most abundant CNS neurotransmitter category. So these are straight amino acids. So let me tell you what I'm talking about. There are 20 amino acids that have ever been found, yes? And you use those to make every damn protein that exists in the world, okay? I don't know if we're on Mars, we might find some different amino acids, but these are the ones we've got, and they make every damn protein that we have. Now, you use them. Of course, you can use amino acids for anabolic processes to build proteins and catabolic processes to make energy. Or, since we already know how to make them, we can use them as chemical messengers, yes? And so you are not going to learn 20 amino acids. You are going to learn the 4 most common amino acid neurotransmitters. So you understand what I mean by amino acids? Okay, so really what these amino acids are is there are going to be, they're a separate category. How are they different from biogenic amines? You didn't change anything about them, right? You could just as easily have used them as part of a protein, okay? So the 4, there are 2 excitatory ones, and there are 2 inhibitory ones. Okay, now, FYI, that's actually kind of the wrong way to say it, because let me back up a little bit and say, can a neurotransmitter really be excitatory, or is it really that it binds to excitatory receptors? Yeah, but that takes too long to say every damn time. So you know what I'm talking about, right? It generally binds to and opens what kind of channels? Sodium, right? And the inhibitory ones generally bind and open potassium channels. But we don't want to make a paragraph every single time we could say a word, right? So we're going to say this is excitatory neurotransmitters. These are the 2 that are excitatory, and they are glutamate and aspartate. Okay, so let's talk about these just a little bit. Okay, glutamate. Glutamate is an interesting one. They are figuring out a lot more about this one. It's primarily CNS, and it's involved in neuroplasticity. You know that word? Neuroplasticity is the capacity of your brain to, for instance, change and form new synapses and prune other synapses, right? It's involved in neuroplasticity and primarily the hippocampus. Do you know the function of the hippocampus? Memory. And also the cortex. The cortex is your higher functionality. So this is a biggie, right? It's going to be really important. And it's especially important at certain portions of your life. Adolescence is a neuroplasticity party, okay? So with adolescence, glutamate is going to be really important. It's important in you right now because as you're learning things, you need to form new synapses, right? And you need to reinforce new synapses. But apparently what they figured out about what's going on with adolescence is that adolescence, this is really kind of counterintuitive to me. What happens right before adolescence is you have more white matter than ever in your brain, a whole bunch of synapses, a whole bunch of connections, right? But then what happens during adolescence is primarily that you start pruning a bunch of this and keeping the ones that you're really going to use regularly, which sounded really counterintuitive until I thought about adolescence. And then, actually that kind of works with how adolescence is experienced, right? Before adolescence, you're really open to everything. And then during adolescence, you kind of you're like, no, this is me. These are the people I like, and this is the music I like, and these are the clothes I like, and this is me, right? So you're really sort of pruning down. And apparently that's what's going on in your brain, right? You're saying not this one, but definitely that one and reinforce that one, right? After adolescence, you actually have less white matter in your brain than you did before. So that whole pruning process goes on with glutamate and the glutamate synapses that you're dealing with. Okay, so clinical connections. Glutamate is also one of the ones that's implicated in ADHD. ADHD is interesting. There's glutamate where there shouldn't be. There's not enough glutamate where there should be. And it's not only glutamate, but it's also some other things. It's also implicated in Parkinson's disease. Now, Parkinson's is mostly dopamine, but it also has some to do with glutamate. And then, have you ever heard of the drug PCP? Have you ever heard of PCP? PCP is not really like big now. It doesn't get much press now, but like I was in school in the 70s and 80s, and the late 70s, early 80s. PCP. Have you ever heard of the drug in which they say, okay, there's this dude who's a 150-pound man and took 6 cops to bring him down? That's PCP. Right. What?
Angel dust.
Angel dust, exactly. That's another name for it. PCP or angel dust. It's not, I don't think it's used really commonly now, is it? Right? I mean, generally people know stories of something, right? You don't have to pretend like you've never known anybody who does drugs. It's just me, guys. You'll be like, oh yeah, my best friend did some PCP. PCP is also the one that makes you kind of dumbass. And you're like, oh, I think I can fly if I walk off the edge of that building. Like, you literally cannot fly and you can't take down 6 cops. But, so that's PCP. It acts at glutamate receptors as well. Ketamine, which I know that you've heard about because people definitely are using that one now. Ketamine is a glutamate antagonist. It's an antagonist to an excitatory neurotransmitter. And do you know what ketamine does and how it's used? Not recreational yet. We'll talk about recreational in a second. Anybody know about ketamine? Go ahead.
Tranquilizer they use for big animals.
Yeah, they do use it for big animals. They also use it for you animals. What?
But I don't know. I thought they were using it more for horses.
Oh, okay. So yeah, it got well known as a horse tranquilizer, but it's really like a mammalian tranquilizer, right? And it actually causes you to lose consciousness, and of course you can't really assess pain if you're not conscious, right? So it was used as basically something to put you to sleep, right? So when you're going to do a surgery, you put somebody to sleep. Do they ever use it in humans? It's definitely not first line in humans, but if, for instance, you had allergies to different other, your anesthesiologist, you had allergies to different anesthesias, it's still in their toolkit of things that they can use, yeah? So it still is. Now, you can go get it to Mexico and get it as a horse tranquilizer. I mean, I shouldn't tell you where to get it, but you erase that last part. So people use it as a fun drug. So it will anesthetize you. If you take enough of it, you're just going to be basically unconscious. You trip out a little bit before you go unconscious and a little bit when you're coming out of the unconscious. And so people actually use it for that reason. And then strangely enough, although they don't know why, it has been used recently in clinical trials because it can actually cause people to have relief from long-term, really resistant depression. We don't know why it works, but if you got somebody who's in a depressive episode and is a manic depressive, right? They've got bipolar disorder, and they're in a depressive episode and they just can't come out of it. And I don't know if you know anybody with bipolar disorder, but sometimes you can stay in the down for 2 years at a time. You hardly get out of bed. And so one of the things that seems to pop people out of really long clinical depressions is a few doses of ketamine. No idea what the hell it's doing up there, right? But you got out of bed for the first time. And they discovered that accidentally by using ketamine on a person during a surgery who was depressed, and then they popped out of depression. So we don't know how the hell it works, but that's ketamine. Aspartate is mostly in the spinal cord and the brainstem, so that's lower functionality, right? Spinal cord and brainstem. It's excitatory in the spinal cord and the brainstem. It has lesser affinity for the same receptors as glutamate. So glutamate's here, right? And aspartate's here, right? So this one will be older functionality that you're dealing with. The receptors for glutamate and aspartate are called NMDA receptors. You don't have to know what that stands for. It's too long. So they use usually the same sets of receptors. They're similar chemically. Okay, and then inhibitory amino acid neurotransmitters are GABA and glycine. And GABA is mostly brain, higher brain, and glycine is spinal cord and brainstem. Does that make sense? So they're kind of the same, right? This one's, so this is my favorite neurotransmitter. This is your chill out neurotransmitter. And I literally have never had enough of that in my life, right? I was like, chill the hell out. I'm like, no, you met me. I started out this way. My husband's like, chill out. I'm like, you married this. This is what you get. spazzy, right? So I need some more GABA in my life. Gamma is gamma amino butyric acid. You can call it GABA, but because gamma amino butyric acid doesn't really mean anything unless you've had organic chemistry, right? Doesn't really mean anything. Okay, so what is the function of GABA? The easiest way to say it is nature's Valium. It is your brain's chill out chemical. It's everything is cool, everything's going to be fine. It makes your brain relax. It relaxes your muscles. It feels really good. So what GABA feels like is like you almost get into a car accident and then you don't, right? And then you give yourself a second and then all of a sudden your muscles all relax and your brain's like, I'm not going to die, right? Right? Or immediately after an orgasm when you literally don't want for anything in the world. That's GABA. Everybody likes GABA, right? GABA is like, everything is fine. I don't even need to seek sex for the next 15 minutes, right? Everything's good, right? So GABA is also what you feel when you take a sip of wine, especially on an empty stomach. Give yourself 30 seconds, hits your brain, and your muscles relax. That's GABA, okay? So GABA feels really good. GABA is very calming. It's your nature's Valium. It's your chill out chemical. So now the clinical connection is that if you can find something that mimics GABA's action or enhances GABA's action, it will be a very good anti-anxiety medication. Yeah? They're called anxiolytic, right? They are anti-anxiety medications. Good? Okay, so anti-anxiety is like the millennial problem, right? Everybody is dealing with potential anxiety. So not surprisingly, messing with these receptors tends to be very attractive. So alcohol enhances GABA's action. It's not an agonist, but it actually enhances the activity of GABA. And you can actually feel it, especially in low doses. Alcohol in high doses can cause more anxiety, but in low doses it can enhance GABA's action. But the one that I really want to talk about, and then we'll sort of compare it to alcohol a little bit, is the benzodiazepines. Do you know that word? Benzos? Okay. These include your anti-anxiety medications, and they are like Klonopin, clonazepam, Valium, Xanax, what else do we have? Ativan. All of those are collectively called benzodiazepines, and what those do is they enhance GABA's action, although differently and far more strongly than alcohol does. And the reason I want to take a minute to talk about these is that these are really differently prescribed in the US than they are in other places, and they're very, very habit-forming, incredibly habit-forming, and getting off of them can kill you dead. So what these should be and are used for in other countries is like rescue medications for panic attacks and anxiety that's like overwhelming. So I've had panic attacks before. I have a prescription for these, but like it just stays in my purse, right? So that if I start freaking out, right, and about to pass out in front of class, which I've totally done before, just pop one, like, and then within 5 minutes, the GABA action, right, is enhanced and it calms me down. But that's not generally how they're prescribed or used in this country, how they're prescribed and used in this country. Am I the only one who knows somebody with a clonazepam prescription? I don't think I am, right? So how they're used in this country is as chronic medications. A lot of people use them for sleep or for anti-anxiety every day. What is the issue with using them that way? The issue with using them that way is that they massively downregulate your GABA receptors, okay? And that becomes a problem. How quickly do they do it? It takes about 2 weeks of using them every day. So if you use them for 2 weeks about every day, I mean, it's person dependent, but that's generally what you need, about 2 weeks. So if I take them 2 weeks and I take them every day for sleep, then, so 14 days, and they downregulate my GABA receptors. What is going to happen on day 15 to my anxiety levels and my sleeplessness when I don't take them? You're going to have massive anxiety and massive sleeplessness. And then what are you going to do? You're going to take another one. And if one doesn't work, how many are you going to take? You're going to take another one, exactly. So what happens is you get into this chemical addiction pathway. It doesn't directly involve dopamine, but it involves GABA. And it involves the seeking behavior because of the anxiety and the sleeplessness when you actually downregulate your GABA. Now, the big problem with that is that going off of them will cause seizures in your brain. It can kill you dead as a hammer. So it is such a big deal, and we take it so seriously that even in Utah, when we are super anti-drug seeking behavior, right? We like do not want you to enjoy any pill that you take. Don't you have fun with that? You like can take it for pain, but if you enjoy it, there's definitely something wrong. Well, with this one, interestingly, even though if you, for instance, are incarcerated, right? If you're incarcerated, then the government is in charge of your pills, yes? If you're incarcerated and you're an opioid addict, they will let you go through withdrawal. But if you're incarcerated and you're addicted to benzos, they have to give them to you, right? They have to keep you on a maintenance dose of benzos because you will die. You will have seizures. So benzos, the way that they're supposed to be used is an intervention, an acute intervention medication, but the way that a lot of people use them is a maintenance medication. What's the problem with using them every day as a maintenance medication? Well, what if the freaking zombie apocalypse happens and you can't get them, right? In addition, by the way, when people can't get prescriptions to these, they start drug-seeking behavior, right? So they start looking for them, they start finding them by other mechanisms. I mean, you wouldn't think that people would be like on the street looking for an anti-anxiety medication, but they sure as hell are. Like benzos, like people will be looking for benzos, right? Benzodiazepines. Does that make sense to you guys? So, and by the way, it can take up to 2 years to get off of benzos. And since they are also muscle relaxers, as you start getting off of them, in addition to your anxiety going up and your sleeplessness going up, you start getting muscle twitches and cramps and spasms. Makes you think you have all kinds of other diseases, especially since you're already anxious. Go ahead.
So what happens when you're on benzodiazepines and then you drink lots of alcohol?
Oh, you're doubling the GABA effect. You should never put those two together. Benzos and alcohol, or benzos and opioids. So benzos and alcohol double the depressant effect, but even more dangerous is what benzos and opioids, because they'll depress your respiration. But a lot of people do benzos and alcohol together. A lot of people do. Okay, so what does alcohol do? Alcohol enhances GABA's action, but it does not do it the same way as benzos, and it doesn't downregulate anywhere near as quickly. So if, for instance, I had 1 glass of wine, we're not going on a bender, every day for 2 weeks, right? On day 15, if I don't have a glass of wine, am I actually going to go into an anxiety attack? No, it does not have anywhere near the efficacy, which is really interesting to talk about here in Utah, because of course you know a huge group of the population under no circumstances would ever have a glass of wine. Yes? Under no circumstances, my mother-in-law included. However, she will take a damn benzo every damn day, every single day, with almost the same effect, but greater propensity for addiction and greater likelihood of killing her, right? So this is an interesting thing. I realize that we don't get into the point that we can actually talk about the pharmacology and that kind of things with people, but it's actually kind of an interesting conversation, right? So anything that came in a prescription bottle is totally fair game for her, right? But if it comes in a nice bottle with a label on it and I have a corkscrew, no way in hell, right? So we've had that conversation before, and she just shakes her head. Go ahead.
Talking about alcohol and adolescents, what is the actual reason for why legal age drinking is 21?
It's completely arbitrary, by the way. It should probably be 25, but you ain't going to get anybody to agree to that. And the reason it should probably be 25 is because the prefrontal cortex, which understands the long-term implications of your short-term actions, is mostly mature by 25. But what they figured out is that at a certain point, especially, it should be 25 physiologically. It should be 18. If you can go to war, you should probably be able to have a cocktail, because then you're going to need one, right? So it's arbitrary. It was an arbitrary number that was decided somewhere in the middle that they could actually have enough public support for. It doesn't have anything to do with physiology, and it wasn't decided when the physiology was known. However, it is probably really good to keep people off of mind-altering substances until their brain is completely developed. Good luck trying, though, because adolescence is also during your experience-seeking phase, right? You're like, your prefrontal cortex is not fully formed, so you can't understand the long-term effects of your actions, and then you're kind of in like novelty-seeking behavior, especially testosterone. Testosterone makes you seek out novelties, which is why you go have sex with somebody inappropriate, or jump off of something, or like run super fast, or do whatever the hell you're going to do, right? So that is the time at which you probably shouldn't, but you probably will do those behaviors. But 21 is just an arbitrary number. It's completely arbitrary. It's 18 in Louisiana, right? And all over Europe, when can you drink? 16? Yep. 16 to 18, depending on the country. Yeah.
18 in Louisiana?
Yeah, it's 18 in Louisiana. It's 18 in Louisiana, and the bars are open the entire 24 hours. They have to close for an hour. They close for an hour and everybody stands outside the bar because they give you a to-go cup,
Schedule.
Until it comes right back in, until it's open again, then you go right back in, right? So you just go like have like a beignet, go back in. Louisiana. Okay, so glycine is the next one. Here's glycine. And glycine is inhibitory, but it's active mostly in the spinal cord and brain stem. Strychnine kills you. Have you heard of strychnine, the poison?
Yeah, don't these are like rat poison?
Yes, rat poison. Strychnine kills you because it's an antagonist for glycine. So it's an antagonist to an inhibitory neurotransmitter in the spinal cord and the brain. It makes you go into seizures when then you die. Okay? All right. So that's GABA. Okay, now let's do the purines. Okay, these are not super complicated. Have you ever heard the word purine? Okay, purines and pyrimidines, two different categories of nucleic acids, right? And so the purines are the A's. So, but ATP is a purine, ADP is a purine, because they are both from adenosine. So I know you know DNA enough to know that A's, T's, G's, and C's, yes? Adenosine is the A. Yeah? Okay, so if you take adenosine and add 2 phosphates to it, you can use it as an energy molecule, ADP. You want to make it higher energy, you add 3 phosphates to it. Yeah? So what I'm saying is that even though you learned ATP and ADP as energy molecules, if your body knows how to make them, it can also use them as chemical messengers, and does. And we were surprised as hell when we figured out that the neurons were actually releasing ATP to actually just cause a response and then reuptaking it. But they're like, I already made it, why not? And you got a bunch of it at the synaptic vesicles anyway, right? Because you need it for exocytosis. So they just release it as a neurotransmitter, which is kind of interesting. So these are, purines are mostly CNS, and the reason you care is because most of us manipulate this one. Because I told you that caffeine was an antagonist to an inhibitory neurotransmitter. It's an antagonist to adenosine. So what adenosine is an inhibitory neurotransmitter in your central nervous system. And when you take in caffeine, you block the effect of that inhibitory neurotransmitter. And then you get excitation of the central nervous system. Go ahead.
That caffeine is
It's on your notes too. Caffeine is an adenosine antagonist. Yeah? So adenosine is an inhibitory neurotransmitter, and caffeine blocks the effect, which causes the excitatory response. That's not all caffeine does, by the way. That's CNS effect. It also, for instance, will cause a little vasoconstriction and increase your heart rate, increase your body temperature just a little bit. But it's CNS effect, and the reason you wake up because of it is because it inhibits the effect. Blocks the effect of an inhibitory neurotransmitter. Good? Okay. So most of us mess with this one, right? We don't all mess with all of the others, right? Oh, I want to tell you guys something cool about GABA before I leave GABA. GABA's my favorite. I love GABA. They figured out that there are other natural ways that you can make yourself release GABA. For instance, if there's somebody you're really close to, having physical contact with them will actually make you release GABA. I know that parents have felt this with their kids, right? You can like cuddle your kids and it'll actually calm them down, and sometimes you're like, oh, I'm calmer too, right? But they did an interesting study just recently in which they figured out that you actually get GABA and oxytocin released when you have 20 seconds of skin-to-skin contact with somebody you really care about. But it also works with your dog. So if you pet your dog, yeah, you'll release oxytocin to bond with them, especially if you look in their cute little puppy eyes. You both release oxytocin. And then when you touch them, you actually release GABA, which calms you down. Maybe other dog people, or is it just me? Anybody a dog person? All right, then you're nice people. I would hang out with you. So what happens, and I had this funny experience with this because this study was only done about 2 years ago and it was published last year. But when my son was little, between the ages of about 5 and about 6.5, he would have kind of frequent night terrors. Anybody else's kids have night terrors ever? Okay, so they're super scary, right? And like I'm fairly certain still that there was no trauma going on in his life, right? And he would just like wake up and he'd be screaming and he would be like look like he was awake, but he wasn't awake, and he couldn't actually take and give information, and it was terrifying. And so tried everything, like mom cuddle him, dad cuddle him, move rooms, get a cuddle friend, turn on the lights, turn off the lights, do whatever the hell. we figured out finally, just anecdotally, that literally the only thing that calmed that kid down was his golden retriever getting up on the bed, and he would shove his hands into her fur, and then all of a sudden, he would calm down. And then, like, just a couple of years later, they figured out that, oh, your dogs will actually make you release GABA. Cats? Mm-mm. They're going to eat you when you're dead. Okay, so that's just neither here nor there. I just thought that was really interesting. I think it works especially well with golden retrievers, but maybe I'm biased. Okay, so now let's move to neuropeptides. Okay, this is just what it sounds like, neuropeptides. Okay, so the neuropeptides, the category that we are going to be called opioids. I can never put the O's and the I's in the right place in that word. Is that right? Opioids, okay. Okay, so before we go any further, I need to teach you a little bit of terminology. Okay, so as we talked about before, huh? No. OP. It's
on ours. Never mind, you fixed it.
Oh, I fixed it. Yeah, I fixed it. Yeah, I told you I always spell that wrong. I'm like, O's and I's for everyone. Everybody have one. So opioids. Okay, so let's talk about the names and what we're talking about before we actually get into the drug. Here's the deal. We have been doing drugs for a hell of a lot longer than we have known anything about neurotransmitters. I had somebody look it up in class last time, and apparently, people have been using opium since 3400 BC. What the son of a? So we named them for the opium, and then later on we actually discovered the neurotransmitter system that opium was dealing with. Does that make sense? So this category of neurotransmitters we call opioids. Do you know the term endogenous? Endogenous means I make it. So an endogenous opioid is an opioid that I make in my brain, right? And then I can take a drug that actually interacts with that system, and that would be an opioid, right? Okay, so my endogenous opioids I make, okay, and the two biggies that you're going to care about, one of them you've heard of before and one of them you haven't. These are endorphins. I know you've heard of those. And enkephalins, which you probably haven't heard of. They just kind of act at a couple of different places in the brain. So I want to tell you before we get into the drugs what the evolutionary reason for these is, as far as we can figure out, the evolutionary logic for having these. Here's what these neurotransmitters do. What they do is they are your naturally produced opioids, and what they do is they reduce pain perception. So let's talk about pain for just a second. You can do pain sensation out here, yes. You can do pain signaling all the way up, and then you can do pain perception in the brain. Now, if you don't perceive it as painful, is it painful? No. But does that mean that the damage hasn't occurred? No, the damage has occurred, you're just not perceiving it as painful. Okay, go ahead.
Wasn't there like some girl born who like didn't have pain?
Yeah, it's massively damaging to not have pain. There's a couple of different genetic syndromes that cause no pain signaling. It's actually a signaling thing.
It's like no pain ever.
No, well, they have no pain, and they chew off their own lips when they're babies. They chew off the tips of their fingers. They never heal their wounds. So as soon as they get teeth when they're babies, you have to protect them from themselves. They will pull out their hair. They will do all kinds of, they'll scratch themselves, and they won't actually feel it. So pain is actually pretty good evolutionarily. So that one is actually a pain signaling disorder. It's genetic. So this one is pain perception in the brain. So here's the deal. I want to think about what else it does. So evolutionarily, why would you have a neurotransmitter that would do this? Because it also does two other things, and I'll talk about an evolutionary example. It reduces pain perception. It also gives you an increased perception of your own capacity. So you're like feeling 10 foot tall and bulletproof, right? And it decreases all of the cautionary signals that go on in your brain, and it rewards itself. So it does tap into the dopamine pathway. And here is an evolutionary situation in which you could see this would be useful. I am on the African savanna, right? And a hyena has just taken my baby. Yeah? A bunch of freaking hyenas, and one of them took my baby. Okay, so what should I do? I should go try to get the damn baby back from the hyena, even though I might die or get injured in the process, right? So what I need to have is an increased perception of my own physical prowess. I'm 10 foot tall. I am also bulletproof. And if I am in pain, which I probably will be, I don't want to feel it, right, at all, or perceive it as painful. And I want to reward myself because what should I do the next time a hyena gets my baby? I should do it again, shouldn't I? Yes? So what happens is these chemicals in your brain are released in situations like that, like Volkswagen falls on the kid. What does the mom do, even if she only weighs 100 pounds? She like tries to lift the Volkswagen off the baby. A, she doesn't like at that moment give a crap that she's never lifted anything above 25 pounds. B, she doesn't know that she just ripped every muscle in her back. And C, she feels super good about her decision, right? So this is the function of endorphins physiologically and evolutionarily, right? And you can see why they would be very pro-survival of the species, right? But I want you to know that they reinforce themselves because they also want to reward you for doing that behavior. So they will cause a release of dopamine in the addiction pathway as well. Okay, so the problem is that, of course, these are very pleasurable. They're pain reducers. And so what we get into is there are opioid receptors. There are alpha, kappa, mu. Mu is the addiction pathway, right? So if you could, you would have one that doesn't interact at mu, but we also really like mu. When opioids are released, dopamine is also released in this portion of the brain that starts the whole addiction or habit reinforcement part called the nucleus accumbens. So now let's talk about drugs, and let's talk about why the hell you would use these drugs for pain treatment. Go ahead.
Does this also apply to like emotional pain, or is it purely physical?
It doesn't really apply to emotional pain, although it does, it doesn't not apply to emotional pain because it kind of tends to dull your sensibilities and your senses to the things around you. And so a lot of times if people are in emotional pain, they can take this because they will feel less of everything, right? Go ahead.
So why does the natural physiology of soldiers, they're stuck in aggressive situations?
Tons of stuff. We will talk about that when we get to stress physiology, which is in the set of notes after muscle. It's a really good question. Huh?
Regulate their sensors?
It depends on how frequently you release it, right? Because even a soldier who's in that situation is not going to be releasing it for hours a day, but for minutes frequently, right? But if you are actually taking opioids for pain medication, you are going to be having these in your system for hours a day. Okay, so now let's talk about using these for pain. Can you see why they would be used for pain? Because they reduce pain perception, right? They're also incredibly effective at reducing pain perception. Can you see why if we knew the wisdom of understanding the physiology that we probably would never have started using them for chronic pain? That they would be used for acute pain, right? I broke something, right? It's broken. It's going to be like starting on the healing process within about 2.5 weeks, right? It is not, for instance, fibromyalgia, which I'm going to have for all of my life, yeah? So what happens in this situation is that medications that interact at specific opioid receptors are very, very habit-forming, and they also reinforce themselves by releasing dopamine. They tap directly into the dopamine pathway. Please remember that the dopamine pathway will also inhibit your prefrontal cortex activity that allows you to conceptualize the long-term impacts of your short-term decisions. Now, before we get into the specific drugs, I want to tell you that generally, not exclusively, people get addicted to opioids because they start out with a normal use of opioids. They are prescribed opioids for some kind of injury, some kind of pain, and then they start taking the opioids, right? But then they downregulate their opioid receptors, right? Also downregulating their dopamine receptors, right? And then they get off of those. And a lot of times they're even taking them exactly as prescribed on the bottle, okay? So they get off of those, and then when they get off of those, they start feeling the pain more, right? And having a lack of pleasure because you downregulated your dopamine receptors. Does that make sense to you? So what happens next is, of course, they start seeking those same chemicals because they're still in pain and they're really, really unhappy about being in pain. They have very little pleasure and a lot of pain. And so they start seeking them. And so a lot of times if you have insurance, you'll just start doctor shopping at first, right? And then if you can't maintain your job because of your behaviors or you can't get the doctors to give you anymore, then you go to the next step and you start trying to find it, off market, trying to find it illegally. And then at some point, quite often, people will figure out that heroin is actually cheaper than Oxy and easier to get. right? Does that make sense? And that's how that progression quite often goes. Not every time, but I know that we think, oh, a heroin addict, I have absolutely nothing in common with them. Just so you know, most of the opioid addicts are middle-class white people in the country, right? They are not street drug users. They are middle-class white people in the country. So this progression goes just trying to get what's available, and then you have actually this habit formation. And when they go off of the drugs, it actually ends up causing all kinds of symptoms. Will it kill you? Generally, no, it's not going to kill you unless you choke on your own vomit, but you are going to want to die during the process of going off of these. So what kinds of drugs are we talking about? We're talking about codeine, OxyContin, Loratab, Percocet. All of those have opioids in them, and sometimes they have other analgesics in them too, like ibuprofen or acetaminophen in them. And morphine, there's a bunch of them. Interestingly, people have been using these for ages, and they were, of course, used for 3,400 years. It was such a damn big deal in China that it was bankrupting the economy because so many people were opium addicts that they started not actually doing anything, right? Because you're just going to like hang out and smoke some opium. You've seen the movies, I've seen them too. So what China decided to do, because China ain't no democracy, China said, well, we have an opium addict problem, so what we are going to do is the penalty for opium usage is the death penalty. And that's how they took care of most of their addicts. They just killed them. And then they didn't have addicts anymore. So around 3,400 years, and now of course we are in a huge opioid crisis in Utah. 20 people in Utah die per day because of opioid addictions. 20 people die per day. So morphine and heroin. Heroin's really interesting because morphine was a big problem, historically speaking, and people were getting addicted to it, especially after wars. Morphine was our primary after World War I and World War II. We actually had morphine and people were using it for pain. Soldiers were in a lot of pain. They were like, oh, morphine's so addictive, we need to create another drug to get people off of morphine, which is why they created heroin. Whoopsie daisy. That's an unintended consequence. Heroin was actually created to get people off of morphine. So these are highly habit forming and subject to downregulation. They're really, really good at acute treatments for pain, but they're a little too pleasurable, especially when they interact with the mu receptor. And so what happened, I mean, I know this about myself. Like, I get prescribed Loratab because of whatever the hell. I actually like it. I think it's super awesome. And then I'm like, oh, brain says you should probably not enjoy this, right? So maybe next time you should ask for 800 milligram ibuprofen. Because my brain is like, woo, that's awesome. Now let's talk briefly. I just want to tell you, because a lot of times people will ask me, I'm not going to ask you about this, but you guys may find it interesting. What about addiction and overdose treatments for opioids? What do those do? How do they interact with the system? You guys have heard of methadone before, right? Okay, so methadone, a lot of times they use, basically, methadone doesn't get you off of opioids. It gives you another form of opioid that you can stay on for long periods of time. So it's basically taking your habit formation, it's at the end. It's taking your habit formation and it's moving it over to something that's federally regulated. So these are long-acting opioids, which means less drug seeking, right? They act for 24 hours. And it's an analgesic, so it's a pain reducer, and it's actually an addiction treatment as well. So it actually helps to keep you from going into the drug-seeking behavior. You're still addicted to opioids. You're just addicted to a more socially acceptable form of opioid that you're probably not going to sell your car. Is it not on yours? Did I change it later? Oh, I can update it. Okay, so have you guys heard of Suboxone? Yeah. Okay, so let's talk about how Suboxone works. Suboxone, and I'm not going to ask you this. Some people are always curious, so I want to tell you. So Suboxone is actually an interesting one because it's an agonist at certain opioid receptors and an antagonist at other ones. It's an antagonist at the mu receptor, which is the really, really addictive one, and it's a partial agonist at the other one, so it's a little bit of pain relief, a little bit of a little bit, just enough pleasure so that you're not miserable, but not like really pleasurable. So that's what that one does, right? And people start seeking that one too. So again, most of the treatment for opioid addiction is moving someone from one opioid that will destroy your damn life to another one, right? It's very difficult to get off of them. It's not impossible. And sometimes they're using this in the progress of getting off of them. And then you guys, I know that you've heard of naloxone. And we have actually, are you an EMT, right? Yeah. Huh? Okay. So naloxone is not a treatment medication; it's an intervention medication if somebody is actually usually going into respiratory arrest. Right? Don't let me say anything wrong. If somebody is going into respiratory arrest, one of the things that a lot of opioids will do is depress your respiratory system and you'll just stop breathing. So if you have anybody in your life who's an opioid addict, and I do, and a lot of you guys do, some of you guys might not know that you do, then this is a rescue medication that it can either be given as nasal spray or an injection, right? Am I saying this right? Do you know all this? Or a nebulizer. And what it does is this one is an opioid antagonist. It's used in emergency situations. It's got no pain relief. As a matter of fact, people hate it the way that it feels when they get off of it because it completely blocks all of your opioid receptors. So why would you use it? Because the person's about to die. It's an intervention medication. And apparently you can get it over the counter now, right? But when you get it over the counter, a lot of people don't know how to administer it. And if you administer it really quickly, it can cause a lot of problems in the person. Don't the medical professionals administer it really slowly by whatever mechanism?
Yeah, a lot of people what they're doing is giving a smaller dose so that someone will just stay kind of dopey,
Mm-hmm.
and then letting that wear off.
And then they can give them more if they need to. Because if the opioids are still in their system and then they bind again, they can cause respiratory depression again, right? If you use it all at once and then you don't have any more of this naloxone. So this one, have you seen the billboards advertising it? They're all over Utah. The billboards advertising naloxone. It's probably not a bad thing to be trained in, or you actually don't even have to be trained. But read all the damn instructions, okay? Because it tells you how to use it. Go ahead. What were you going to say?
I'm just saying there's a lot downtown.
There's a lot of those
Like
billboards.
reading onto iPhones.
Yeah, I know. I live downtown. That's probably why I see them. You may not see them out in West Valley, but you should definitely have some out in West Valley, honestly. Come on, guys. What?
Don't we give it out for free?
Probably. I don't think I get it for free. They sell it over the counter. Oh, okay. I'll go to the fire department. I actually know a fire chief. So anyway, that's how that one works. So we can get back here, and we'll take our last few minutes and introduce you just to a couple more, and then we'll talk a little bit about marijuana today, and then we'll talk about it again more next time. Okay, so as we're all feeling super, super superior to junkies, I want to tell you that you're all a junkie for something. You know, whether it's naturally released GABA or serotonin or whatever, or they figured out just recently that sugar addiction, which doesn't seem like a real thing, just like, oh, you just made that up. Unless you're a type 1 diabetic, right? And then it's a thing. Yes? So how do you keep somebody from killing themselves with a sugar addiction? And by the way, in Utah, sugar is your thing, man. They don't even have swigs anywhere else, right? Where you can drive through and get like a maximum concentration of sugar in the smallest package possible, like all of the sugar in there. So sugar addiction is actually circumvented with the same drugs that they use for opioid addiction. So as we're all feeling superior, just realize you're just a different brand of junkie from everybody else, but we're all junkies. So that one is sugar addiction. And then the last one is this neuropeptide that's not an opioid. It's not particularly clinically important yet, but I think it might be. That's why I want to tell you guys about it, just briefly. So substance P is a neuropeptide neurotransmitter that's involved not in pain perception, but in pain sensation. Yeah? And so that one doesn't tap into the dopamine pathway. It's mostly PNS and not CNS. And they're in the process of getting it toward clinical trials in humans. And it might be something that would be useful for an analgesic in the future. So I just wanted you to know that it existed in case you hear about it in the future. Okay, so with our last few minutes, let's briefly start the process of talking about marijuana and cannabinoids and THC and all of that business. We won't finish it today, but we'll barely get started in it. Okay, so this whole chemical category of neurotransmitters is called the endocannabinoids. Endocannabinoids. Why endo? Because it's endogenous. Why cannabinoids? Because we found cannabis long before we found the neurotransmitter, right? Does anybody know how long we've been using cannabis? I asked them, and somebody look it up for me and teach me, okay? Because it's been a long-ass time. Not 3400 BC, but a long time, okay? So historically, like how long have we been using this chemical? So We only discovered the neurotransmitter that marijuana actually works, that system, in 1992. That, like, I know some of you guys are way younger than me, but to me that sounds like yesterday. And some of you guys are like, I was born in 92. Well, you can shut up. And the one is anandamide. Okay, and ananda is Sanskrit for bliss. So when they found it, they called it the bliss neurotransmitter. So anandamide is a lipid-soluble neurotransmitter. That means it gets picked up very quickly, has no problem moving into the system or moving into the brain. It's discovered in 1992, and it is involved in a bunch of different things, but the things that are relevant to clinical situations, and the reason that in many states, every damn state's touching us, really, it's legal for medical marijuana is legal, is because it is involved in pain signaling. So you got pain sensation, you got pain signaling, right? And then you got pain perception, yes? So it is involved in pain signaling. It's also involved in working memory, eating, sleeping patterns, and pleasure and food rewarding, but not via the dopamine system. It doesn't tap into the dopamine system at all, which is pretty damn important. What's the answer?
Earliest written reference to cannabis dates back to 2727 BC.
Oh my gosh, we have been junkies for
From
so
the Chinese
long.
emperor.
Chinese? Chinese people were born before the rest of us, apparently. They're like, what the hell does this thing do? It's because they've had civilization. They're like, I'm annoyed with all of you.
Central and South Asia.
Central and South Asia? Oh, okay. So I want to tell you just a couple, just teeny bit more, and then we'll leave this for next time. So why would some people consider an anandamide agonist, like THC or some of the other chemicals in marijuana, a better use for chronic pain, a better treatment for chronic pain than opioids? It doesn't tap into the dopamine pathway. It ain't going to kill you. And then please remember that with a lot of chronic pain situations, you also completely lose your appetite, which causes problems with getting adequate nutrients. So I want you to think about a cancer patient, for instance, right? So if you can get the double benefit of decreasing pain signaling and also increasing appetite, then with chronic pain, sometimes this is a double benefit for chronic pain. However, apparently in Utah, we're still not willing to have that conversation yet. But what I want out of this is really just that you go and educate yourself enough that the next time you vote with a lot of information behind you, even if you completely disagree with my vote. And I don't even like marijuana, but I think cancer patients should be able to do whatever the hell they want, honestly. You're like, you got cancer, you do you, man, right? You do that, whatever. So every state around us has legalized medical marijuana, but not Utah. So we'll talk about that one a little bit later. I'll tell you a little bit more about how it works. And we actually, there are receptors for anandamide all over the brain. Okay, we'll stop there. Okay.